Hello, I'm Mallie Shansfeld, Managing Editor of Pediatric Dental Practice US, a Medmark publication. Welcome to an educational presentation and question and answer with Dr. Sara Ruby. In our webinar today, we will be discussing the use of bioceramics and pulpal therapy in primary dentition, along with indirect and direct pulp treatment in immature adult teeth. Before we get started, I'd like to invite viewers to use the question and answer box to ask any questions. They'll be answered at the end of the session as time permits. Now I'm pleased to introduce our speaker. Dr. Sara Ruby earned both her undergraduate degree in biological sciences and Doctor of Dental Medicine degree at the University of Pittsburgh. She then completed a general practice residency at the Ohio State University College of Dentistry and University Medical Center. After practicing general dentistry for 12 years, she then returned to the University of Pittsburgh School of Dental Medicine in 2016 to obtain specialty training in pediatric dentistry, where she completed her research project in infant oral health. In addition to being board certified with the American Board of Pediatric Dentistry, she's an associate clinical professor in the Pediatric Department at the University of Pittsburgh School of Dental Medicine. Dr. Ruby is also an active member in the American Academy of Pediatric Dentistry, American Dental Association, Pennsylvania Dental Association, Dental Society of Western Pennsylvania, the Pennsylvania Academy of General Dentistry, and a fellow in the American Academy of General Dentistry. In her spare time, Dr. Ruby enjoys spending time with her family, 2 young daughters, and golden doodle, Rose. She also loves going to Pittsburgh sporting events, concerts, and traveling. Thank you so much for joining us, Dr. Ruby. We now turn the webinar over to you to learn more about today's topic.
Okay, thank you for having me. And I hope everyone is staying warm out there because it's very cold where we are. But today I'm going to talk about the use of bioceramics in pediatric dentistry with successful behavior management techniques. The agenda today is we're going to talk about the pulp therapy and the diagnosis of the pulp, vital pulp therapy in primary and immature adult dentition, non-vital pulp therapy in the primary dentition, non-vital pulp therapy in the adult dentition, and behavior management techniques. So what is pulp therapy? So pulp therapy, the primary goal is to maintain the integrity of the tooth and the supporting structures. This pulp therapy may be indicated for a small pinpoint exposure, a carious pulp exposure, deep caries with no pulp exposure, or pulp exposure due to trauma on vital tooth. The extent of decay and the health status of the pulp tissue determines if the pulp therapy is indicated, if at all. Also keep in mind the tooth must be restorable. Vital pulp therapy for primary or immature teeth is indicated if the tooth is diagnosed with a normal pulp or reversible pulpitis. Non-vital therapy for primary teeth is indicated if the tooth is diagnosed with irreversible pulpitis or necrotic pulp. Non-vital pulp therapy for permanent teeth treatment depends on the formation of the root and again if the tooth is restorable. So pulpal diagnosis should be determined first before you decide what treatment to do. Teeth really only hurt if they're infected or trapping food. So you want to talk about your findings with this tooth, both clinically and radiographically. The diagnosis of the pulp, we need to consider all of these findings. So some clinical findings might be discomfort waking the child up at night, an unprovoked tooth pain, mobility, a fistula that's seen, gum or facial swelling. Some radiographic findings you might find are bone loss, root resorption, radiolucency at the furcation or the apex. So you really want to take a look at your radiographs along with the symptoms the child is complaining of. So a tooth with a normal pulp is symptom-free and has a normal response to pulp testing, and there's no periapical pathology on the x-ray. Reversible pulpitis, the pulp tissue is capable of healing. So for instance, with this, a patient may have discomfort here and there if they're trapping food in the tooth, but it's not really keeping them up at night, and there's no swelling or any radiographic evidence of an abscess. Symptomatic or asymptomatic irreversible pulpitis, the vital inflamed pulp is incapable of healing. So that's where you might find swelling or nocturnal pain, and a lot of times antibiotics are prescribed until the tooth, to help with the tooth discomfort until it can be restored. And the necrotic pulp, the tissue is dead. Sometimes it has no symptoms, sometimes it does, and you may see the evidence of necrotic pulp on the x-ray as well. So vital pulp therapy for primary teeth. There are a couple different ways to do this depending on the situation. So protective liner, that's a thin layer that is placed on the dentin in proximity to the underlying pulpal surface of the deep cavity preparation. Its goal is to promote tissue healing, tertiary dental formation, and minimize bacterial leakage. So anytime I do a filling and I haven't quite gotten to the pulp, but I've removed all the decay and I know I'm close to the nerve, I will put a liner down to protect the tooth from the etch and bond before you restore the tooth. Indirect pulp treatment is a procedure where the deepest caries are left behind, adjacent to the pulp. You want to leave it undisturbed in the effort to avoid a pulp exposure, where a biocompatible material can be placed to produce a seal, and then the tooth is restored after that. When removing these caries, you want to make sure you get it from around the circumference, and that's all without caries so that you can seal it effectively. The next option you may choose is direct pulp treatment or a pulp cap. This is the placement of a biocompatible material to seal the tooth and prevent microleakage after a pinpoint exposure of 1 millimeter or less, with caries removal or trauma, and then the tooth is restored. If you have a pulp exposure that's bigger than this, you're probably thinking of a full pulpotomy. So the pulpotomy is the removal of the coronal pulp tissue, hemorrhage is controlled, and then the tissue surface is treated with a long-term, clinically successful medicament and then restored. So I usually don't do a direct pulp cap in primary teeth, but I will do it in permanent teeth. Instead, I would go ahead and do a pulpotomy. I do find I do a lot more indirect pulp treatment, leaving a little bit of the caries than getting close to that pulp. And there is quite a bit of research on the success of indirect pulp treatment. So medicaments you might use in this vital pulp therapy, when you're using that liner, it might be something like Vitribond or Limelight, some kind of glass ionomer. I like to use the BC liner. For the liner, not the putty, but I like to use the liner there. If I'm doing the direct pulp cap or the direct pulp treatment, I'll use the pediatric putty and then put the liner over top of that to seal it. Some people may also use MTA, resin modified glass ionomer, or calcium hydroxide. With the pulpotomy, that's where you removed all the coronal tissue. You can use the Brasseler Endosequence Pediatric Putty, MTA, biodentine, former creosol, ferric sulfite, and then you would place IRM. Calcium hydroxide is not recommended for pulpotomies on primary teeth. Just to go a little bit deeper on these medicaments, so the protective liner placed on the dentin in the proximity of the underlying pulp surface of the deep cavity preparation acts as a barrier. And it's very important you have that barrier before you place your restorative material or cements. The goal is to preserve the tooth's vitality, promote tissue healing, tertiary dentin formation, and minimize microleakage. It also will minimize your sensitivity too. So a lot of the medicaments that I use are calcium silicate cements, such as the MTA, biodentine, and the Brasseler products too. They create precipitates that are similar to hydroxyapatite when in contact with the phosphate ions of dentin. And then placing a definitive restoration on the teeth right after that really is ideal. Whether it's a filling or a stainless steel crown, you want to make sure it is sealed. So I love using the pediatric pulpotomy, mainly because it's easy to use. It's highly biocompatible and osteogenic for superior healing. It's highly radiopaque, so you can see it on the X-ray, and hydrophilic. It has a small particle size to make it easier handling. It bonds to the dentin by leveraging the natural dentin moisture, and it has the antibacterial high pH. And you could see what the chemical makeup is of those, of the pedo putty. You can buy it in a 1 syringe or 6 syringes. And out of one of these tubes, I could probably do 8 to 10 pulpotomies. I also use the endosequence liner. I will use this as a liner when I'm doing a deep restoration or to seal over the putty to make that barrier so there's no micro leakage. This is also a bioactive hybrid resin restorative material. It's easy to dispense. It's dual curable. It chemically bonds to the dentin and seals against the bacterial leakage. It continuously releases and recharges calcium, phosphate, and fluoride ions. And it really has a compressible strength and a good flexural strength. You could see the makeup of this material as well. So this is a case that I had. This is a a 5-year-old, 8-month patient who was treated under IV sedation. The teeth were asymptomatic at time of restoring. You could see there is a smaller cavity on L, but tooth K has really deep decay that's almost right up next to that nerve, but the bone health looks fine, and again, the asymptomatic. And here's the post-op X-ray I took that day showing how the coronal tissue was moved. You can see the putties there and the BC liner I placed over top, and then my glue for the crowns. So here is the picture of the pulpotomy on K. You can see how all the coronal tissue is removed and the decay. Hemostasis was achieved with just a damp cotton pellet on the nerve. If the hemostasis cannot be achieved in a reasonable manner, in a reasonable time, then that may be a tooth that should be extracted or a pulpectomy is done. I usually want the hemostasis to be done in 2 minutes or less, especially if it goes longer than 5 minutes, I'm not restoring this tooth with a pulpotomy. So being with pulpotomies, it's really done on primary teeth, but can also be done on permanent teeth. So you're amputating the coronal pulp, you're getting the hemorrhage controlled, and the remaining vital radicular pulp is treated with a medicament, and that is the putty that I'm talking about, or some people use MTA, ferric sulfate, former creosol. So that's important to keep in mind. So this is tooth K. You can see where I placed my putty over the, and it doesn't take much of the product at all. It's maybe 1 millimeter or 2 millimeters thick. And I like to pack it with a wet cotton pellet and cotton pliers. And then I sealed it with the BC liner. So you can see the liner over top of the putty to make sure it's sealed, because the putty does take some time to harden fully. And then these are the teeth restored. As you can see, I'm using a rubber dam for isolation to keep my field clean and not worry about anything else getting in the way. This is another case, kind of the same thing, same teeth. On this tooth, tooth K, I just put the liner in because I did not have to do a pulpotomy on it. You could see on tooth L, I did the pulpotomy where I have the putty in there. And then this second slide is showing the putty on both teeth, right? And then I have the stainless steel crowns. Again, using a rubber dam for isolation. It's my preferred method when I'm doing sedation cases. I do use a dry shield when I'm doing awake cases, and we'll talk a little bit more about that in a minute. But real quick, going back to my pulpotomy slide, I want to talk about former creosol. I used to use former creosol for years, but the time of the pulpotomy was a lot longer than using the putty, because you have to get hemostasis, and then you put in the cotton pellet with the former creosol, and that's supposed to stay in there for 5 minutes. And 5 minutes is a really long time when you're working on sedation, and I don't want to have to wait 5 minutes. Not to mention, it can be seen as a potential cytotoxicity and gets considered a carcinogen. People don't want that to be used in their teeth anymore. It's still a widely used medicament to use for pulpotomies because it has the bactericidal properties of the formaldehyde that fixes the pulp tissue, kills the bacteria, and preserves it. But since switching to the putty for the past 6 years, I just saved so much more time. Someone else, MTA or Biodentine, they're also good bioceramic products with the tricalcium silicate that you could use. They're bioactive and biocompatible. I just love the ease of the putty because I don't have to mix anything, and it's reasonably priced now that they reformatted it as pediatric putty. Ferric sulfate is another thing you could use as a medicament to do your pulpotomy, and it aids in hemostasis. It may be, I never liked using ferric sulfate because I feel like I didn't have a good idea if that pulp tissue was still aggravated, because it's gonna, no matter what, it's gonna clot the bleeding, and the prolonged hemostasis that tooth might have may be masked with the ferric sulfate because of how good it aids in hemostasis. So in that case, I may be restoring a tooth that's otherwise I would have extracted if it was still hemorrhaging a lot. Other people may use lasers or sodium hypochlorite, but they have conditions to their recommendations, and calcium hydroxide is not recommended in pulpotomies. So going on to vital pulp therapy in immature permanent teeth or mature permanent teeth, you could do a liner. Just like the baby teeth, you can do indirect pulp treatment, just like we discussed before, direct pulp cap. Sometimes you do a partial pulpotomy on adult teeth instead of a full pulpotomy, and then a complete pulpotomy, and then also apexogenesis if the root is not fully formed. So this case is a 14-year-old, so obviously his roots are mostly developed, but as you could see, he hit a wall playing basketball and he chipped both of his teeth. And over here you could see the pinpoint pulp exposure, so you don't want to just fill that. You want to aid the pulp in healing, right? And then this is the x-ray before we did any treatment on this child. So this is it fully restored. You could see this little white dot is my pedo putty. And then I put the liner, and I had to be really thin with it because I reattached the tooth that he had brought in, and then just put some resin composite over the facial to give it some added strength. And then we talked about wearing his sports guards more often if he's playing that physical of a basketball game. You could see he has Invisalign buttons. So he was Invisalign, but also wasn't wearing his trays during his basketball game. So after we restored this, he had to go back to the orthodontist and be rescanned for new trays because it's almost impossible to make them exactly the same. This is another patient. This is a 12-year-old, and he has very deep cavities. You could see this is tooth number 30. The decay, I knew before going in here there might be a pulp exposure. So you could see the pulp exposure there and a little bit of that dentin, like that leathery dentin that you could still leave to do your indirect pulp treatment to not open up this whole tooth and do a pulpotomy. But you want to make sure the margins are really clear around it because you don't want there to be any decay around that tooth. So here you can see where I just put a little bit of my putty over that pinpoint exposure, and then the BC liner over top. And then this is it fully restored. That tooth did have a little bit of hypomineralization, so that's probably why he had such a big cavity in that tooth compared to the rest of his mouth. You could see my resin that I just put in, and then the x-ray. You can see that little dot there where the putty is, and then my BC liner, and then my filling over top. And it's very important to restore this more definitively that day. You don't want to put a temporary filling in there because you don't want there to be any leakage. And I always tell the parents, if this happens, um, that filling was really deep. The hope is that tooth will stay vital, but signs and symptoms to look out for: if the tooth is sensitive to hot and cold makes it feel better, it's waking him up at night, or there's any swelling, to let me know, because then we're going to do a conventional root canal therapy on that tooth if the roots are fully formed. If not, we might do a full pulpotomy, or even apex apexification. So the primary vital pulp therapy recommendations are and outcomes. There are similar success rates with doing indirect pulp treatment, a direct pulp cap, and a pulpotomy. And the choice of the pulp therapy should be based on the biological approach of the caries, affected dent removal, such as how big is your exposure, any reported adverse effects or symptoms they might have, the clinical expertise and how comfortable you are in doing these procedures, and then the patient preference. So in some studies in our AAPD guidelines, states that indirect pulp treatment overall success rate is 94.4% after 24 months and 83.4% after 48 months, which is 4 years. And, depends on the age of the child when you're restoring this. Sometimes we don't even need the tooth to last 4 years. Direct pulp cap, the overall success rate is 88.8% after 24 months. And then the pulpotomy overall success rate is 82.6% after 24 months. So you could see a lot of times I do this indirect pulp treatment, leaving that little bit of carious dentin that's much thicker and leathery, and I seal it with a biocompatible liner, such as the BC liner, do my filling over top. But if I do get a pulp exposure, then I either have to do the direct pulp cap or the pulpotomy. It is important to be able to monitor these patients as well. So you want to choose the most definitive treatment. So for instance, I have a child that's coming 3 hours away, treatment under sedation. Parents and child have a very poor dental IQ. I'm going to want to do the most definitive treatment, and sometimes that even means extraction. So now we can talk about non-vital pulp therapy on primary teeth. I don't usually do these procedures because a lot of my patients come from so far and I can't keep an eye on them. So I'm usually extracting the tooth, but you can do a pulpectomy on primary teeth. It's indicated in the treatment of dead, dying, or abscessed teeth with no root resorption. The pulp is removed and the canals can be filed. And then you can place the zinc oxide eugenol iodoform paste, which is Vitapex, zinc oxide iodoform with calcium hydroxide. Some people use the lesion sterilization tissue repair, and it's where you kind of, some people remove the tissue, some people don't, but you place that 3 antibiotic paste, which can be made at your pharmacy if you want to do this procedure. And like I said, it could be placed both with and without tissue removal. And then sometimes you have to decide to extract the tooth if that crown of the tooth is not restorable due to inadequate healthy tooth structure, extensive root resorption, or the patient can't be closely monitored. Non-vital pulp therapy on permanent teeth, you're either doing a pulpectomy, which is a conventional root canal. Apexification is root end closure, and this is indicated when the immature permanent tooth still has an open apex. It's not done forming the roots. So you can seal the bottom of the roots with MTA or other silicate cement like the putty, and then the root canal is completed over top of that. With that being said, I'm not doing that procedure. I'm sending it to an endodontist who's going to use a microscope because I feel that these days most endodontists are using a microscope, and they're going to be able to see way better than I can. Regenerative endodontic is indicated with a necrotic pulp and incomplete root formation where the damaged pulp tissue is removed and you stimulate growth of new tissues, such as you remove that tissue, cause some bleeding. You can either put stem cells or pulp transplants or even bioactive material like MTA, kind of trying to get the tooth to remake its pulp tissue. Or extraction. This procedure is indicated when the tooth is deemed non-restorable because of inadequate tooth structure or extensive root resorption. So these are some isolation techniques that you can use. There's several of these: dry shield, isovac, isolate. The isolate on the upper right corner you can see also has a light in it. I do not use this product. I use the dry shield mainly because they have so many different sizes of mouthpieces and they are sterilizable, which is great. So you can reuse them. They're also really, really soft, and I feel like they're not as stiff as some of the other products out there. Where I teach at the dental school, we use the isovac, and you have to take all this apart and sterilize this. The mouthpieces are not sterilizable. But it's nice because you don't need to buy this suction part. It just can go on to any high volume suction. And then again, the old standard is the rubber dam. I do love using a rubber dam, especially in sedation, and it's much quieter. It still works. I like to use I think it's a size 2 clamp. It's a premolar clamp. And you could see when I put the clamp on, I don't always clamp the neck of the tooth. I get down below the tissue and find that root and engage it there. And I can do a split dam so I can see my fields. A lot of times with doing this, I'll do I don't numb in sedation, but I'll do this intrapapilla injection of lidocaine, so then it also keeps my field more clean and a lot less bleeding. So I always like to talk about behavior management techniques in my classes because I feel like I try to make it a black and white thing, but it's not, right? Behavior management is just managing the behavior of your patients. When you treat adults, you can just communicate with them usually and it's fine. But when you're working on kids, there's a lot of other ways to do it, such as communication and communicative guidance. Maybe saying, hey, please sit still like a statue. That really helps me get done quicker. You're just communicating with them, telling them what you want. Positive pre-visit imaging is maybe making a storybook or having them look at a video or a Daniel Tiger video to kind of get an idea of what's going to happen, but in a positive manner. Direct observation is where you might be watching an older sibling or be a better behaved sibling go first, or maybe another child. So they're watching how you're supposed to act. Tell, show, do is another technique. And that is where I tell them when I'm going to do it and I show them and then I do it. And I love this. I probably use this with everyone because I want to show them on their hand what they're going to feel. I will test the hand pieces out on their hand without any burrs in them, of course, just to show them you're going to feel air and water. You're going to feel vibration. And then when you do it, they're not as startled. I also like the ask, tell, ask technique where I ask them, hey, do you have any concerns about today? I tell them what I'm doing and then ask them if they have any other questions. I think this works well with teenagers because they're afraid to talk. You got to kind of engage them sometimes to get what they're thinking out of them. Voice control is one I don't like to use, and I don't think that parents really are okay with it and these new parenting styles there are today. Voice control may be raising your voice saying, oh, I need you to sit still. And using that tone and change in your voice really gets them to listen if they're distracted. Nonverbal communication, that's as easy as touching their shoulder, smiling so they can see your eyes smile, just showing them it'll be okay. Positive reinforcement and descriptive phrase, that might be saying, oh, I love when you sit so still. I can get this done. Remember how well you did last time? Let's do that again. Distraction can be done all kinds of things. Watching TV, I have a therapy dog, jokes. anything like that, talking about their dog or maybe what they got for their birthday or their favorite foods, and trying to keep their mind off of what we're doing. Memory reconstructing, that's just taking a really good visit and talking about that and ignoring maybe the negative visit they might have had before. Enhancing control, this is again a great one for teenagers. I might say something like, hey, if you feel something, raise your left hand and let's practice that. But if they do raise their left hand, you definitely have to stop and make sure that they see they have control over their dental appointment. Parent presence or absence. Some pediatric dentists don't want the parent there. I love when the parent's there because if I'm working on tooth A and now B has a filling, I can get verbal consent from the parent right then instead of having my assistant go out into the waiting room. Or if I need to change this nitrous appointment to a sedation appointment, the parent can see how well we do at trying to comfort that child, but they still are not able to tolerate the work, either because they're too anxious or their mouth is too small and you can't even get a handpiece in there, or they've got a really strong gag reflex. Sensory adapted dental environment, that is like a sensory room that we have in our office too, and it's better lighting, lots of things to the child to interact. You might do an exam standing up or sitting down, but just not in your normal dental chair. Animal assisted therapy is therapy dog. I have a therapy dog that comes to the office certain days a week, and the patients can pet the dog. And that really helps distract them and calm everyone in the room. A picture exchange communication system, that's where I might have a little whiteboard and I have different pictures of things I'm going to do and just let the kid check off the box as they complete. Oh, first we're going to look with the mirror, then we're going to use our prophy cup, and then the doctor is going to come in, and then we're going to apply the fluoride, and just give them a sense of accomplishment by checking it off. Nitrous oxide, oxygen inhalation. I use this a lot. I think this helps keep them stable and more sitting still. They're still awake the whole time and able to interact, but it kind of just takes the edge off. Everything I do isn't as loud or intense. Even if I just use it to give them the injection and get them numb, and then I take it off, it's still really making it easier on the child. And then advanced behavior management technique is protective sterilization or protective stabilization with a papoose board. I don't do that, but it is widely used at the dental school and with other pediatric dentists, or just putting them to sleep, where I do a lot of sedation where I have a dentist anesthesiologist come in and put them to sleep in the office. So this is, for example, the therapy dog sitting on the lap. The person who has the therapy dog is always with the dog too, to make sure that, and then she's certified and all that stuff. So it just helps break barriers, reduces the stress, decreases perceived pain, and it's a calming distraction. And this is my pre-operative imagery of the storybooks we'll do. They show positive radiographs of their dental visits before, and even has their picture in it sometimes, and then other pictures in the office so that they know what to expect when they come back. So these are some of my references that I use, and I definitely, I love, if you want to treat children, the American Academy of Pediatric Dentistry has a reference manual, and anything that you would do in pediatric dentistry, there is a guideline or studies and exactly the steps that you should be doing. So we're very lucky to have that. So I don't know if anyone has any questions. We can go over that, but thank you for your time.
Oh, thank you, Dr. Ruby. That was really interesting. There are some questions, but before I get to those, I would like to invite viewers to use the question and answer feature in the control panel on your screen to ask any questions. First question, are there any cost considerations to adopting bioceramics?
Well, the bioceramics is definitely more expensive than ferric sulfate and fluorocremosol. However, the time I save with these products, I believe it's worth it because I can do a lot more dentistry. There are also less retreats with these products, and the success rate's higher. The packaging nowadays is changing. So they, like, one syringe can be used for multiple cases versus when there was MTA and it was a single use. And the shelf life is longer now too. So I think it is becoming a lot more cost effective.
Okay, second question, what training or learning curve should I expect when incorporating bioceramics?
I think there's a small learning curve with the putty. It's just, but it's easy. Just knowing how much to use and how to pack it. And once you really start playing with the material a little bit more, you know exactly how much putty you'll need to cover the orifices, and then exactly how damp you want that cotton pellet to be able to pack it quickly and efficiently.
Are there any specific cases where bioceramics may not be recommended?
I would say if the tooth's not restorable. Other than that, I use them with any time I have a deep carious lesion or a pulp exposure.
Are bioceramic materials available just in North America or worldwide?
The brasso materials that I've talked about today are just available in North America, and Canada and the USA. So I'm not really sure about the other products.
Okay. And last question, are there specific studies or data that can provide information on bioceramics durability and clinical performance over more than 10 years?
There are several studies showing the success of bioceramics in dentistry dating to the early 2000s. Many of them are in endodontic journals. These materials were mainly used if you perfed doing a root canal through the side of the tooth to help seal it, and being more biocompatible. Some of these research studies are comparing the products, and some of them are discussing the success. And they're comparing different products and pulpotomy procedures, also root canal treatments as well in adult teeth. You could always go to www.pubmed.gov and use searches such as calcium silicate cement, vital pulp therapy, biocompatibility, and a bunch of research studies should come up there. And then also going to the pediatric reference manual and guidelines, all of their guidelines have a ton of research articles that they cite that you could follow up with.
Well, thank you, everyone, for your questions, but we've run out of time today. But if we did not get to your question, we will answer it after the webinar via email. Thank you all for attending, and a special thank you to Dr. Sara Ruby for your great presentation, and our sponsor for this webinar, Brasseler USA. Thank you, and stay safe out there.
Thank you.